Hi, I'm Danica Koopmans.
And I'm Sharon Hughes-Geekie. We're your hosts of Docs of Vernon. This is an interview and podcast series designed to help you navigate the healthcare system and get to know the physicians that provide your care.
Topics include what the heck is a hospitalist, treating addictions, and alternatives to going to the ER, plus so many more.
This is your link to healthcare in your community.
Hello and welcome back to the Docs of Vernon interview series. I'm so excited. Today I have the privilege of interviewing Dr. Nikki Kirkpatrick, and we have a super interesting topic to speak into today, so we'll just get going. Dr. Kirkpatrick is a CCFP trained emergency medicine physician actually who started her career in the Okanagan and Salmon Arm. And then she had already moved to Vernon from Vancouver Island in 2011, but was previously working in Salmon Arm, and then came to join our hospitalist group when?
Oh, that's a good question. Around, I think, 2017 or 18.
Okay. Yeah, so she's been here a little bit of time. Recently, she's been working with the North Okanagan Hospice Society, supporting in their pilot project for the At-Home Hospice, or Hospice at Home, I should say. She's a mom. She's going to Paris soon with her daughter. She loves the outdoors and traveling. So welcome and thank you so much for being here.
Thank you for having me.
Yeah. So today is an exciting day and an interesting day, and I expect lots of questions after this as well. We're going to speak into palliative care, MAID, and a little touch on the MOST form.
Okay.
So I just wanted to ask you, generally speaking, the difference between palliative care and what MAID is from a very general context, because it's pretty complicated when you get into the details of it.
It's important to know that palliative care is sort of an umbrella term. I think a lot of people associate palliative care with end-of-life care, which it certainly includes, but palliative care is more a lens that we look at someone's care through. So when somebody's been diagnosed with a life-limiting illness, it can be something like a cancer that's spread, or end-stage lung disease, or end-stage heart disease, end-stage kidney disease. We try to include palliative care as part of the care that we provide. It really refers to providing someone with the best quality of life in the time that they have left, given that they have an incurable illness. It really can vary how much actual palliative care a person needs, depending on where they are in their disease process. So early on, someone could need some pain and symptom management, which is part of palliative care, but they could also still be undergoing something like chemotherapy to try and slow the progression of a cancer down, or radiation therapy, or the newer medications called immunotherapy. As their disease progresses, though, maybe there are fewer active treatment options, and we're leaning more towards symptom management to give that person the best quality of life that they can have. Good palliative care, I think, can go on for several years even, and it certainly involves a lot more people than a physician. It involves physiotherapy, occupational therapy, making sure you have the things in your home that you need to stay at home as long as you can, if that's what you want. It involves good spiritual care, social workers to get involved to help handle all the things that come up at end of life.
And I'm sure you've seen recently, really beautiful end-of-life care, and then often a struggle too. So what do you feel are kind of the strengths in starting the conversation early with palliative care?
I'm quite passionate about people having advanced care plans in place. I think that's something that while you're healthy, you should put that in place.
Yes.
Those are discussions about what you would want to do in the event that you got sick. Discussions that you open up with your family in case they're ever in the position that they have to make decisions for you, that you've thought about what it is that you would and wouldn't want. Obviously, those discussions they evolve depending on where you are in a disease or in your health. So what you would accept when you're 25 might be very different than what you would accept when you're 85. And so learning what questions to ask of your physician, how to have those conversations with your family, what kind of documents you might need in place, I think those are all very important things.
in a gentle, nice way, sometimes people can really fight end of life, and it can become very painful and difficult on family and friends and those around us when we could have mitigated all of that. And so I think the question is like what you're saying, like speaking into advanced directives, but also speaking into like what has a really beautiful end of life been? Because I think we think of death as a failure or a fear, or, you know, at least for myself and my patients, what I've experienced is just there can be a fight. I've also experienced really beautiful peace, release, comfort. And I think you're in a position to provide that with all the work that you're doing.
Yeah, I think you're exactly right. It can be quite different for different people. I think one of the things that makes me passionate about palliative care is it kind of like emergency medicine. You can, as a physician, you can have a real impact on someone's life in the emergency department, but I think that's also true of palliative care, that you can really have an impact on a person having a good death. As good a death as they can. Death is something that we don't face a lot in our society anymore, and a lot of us have never actually been around someone who's dying. You know, they're difficult conversations to have, they're difficult things to think about. I think the more that we can think about them and prepare ourselves and prepare our families for what's to come, the better that can be, and certainly a good palliative care team can go a long way in helping people navigate that, because a lot can come up at that time, you know, a lot of fear, a lot of existential crisis, spiritual crisis, you know, all on top of what you're going through physically. So a good death to me really involves a team that is there to support you in all those things. I think death is one of those things that really brings out our common humanity. You know, if there's one thing in these divisive times that binds us all together, is that we will all die, and that we all deserve the best death that we can have. I think that's what palliative care is about.
Nailed it. That was so beautiful. Thank you. Okay, so one of the things I had a question about is regarding palliative versus MAID. And I say that very distinctly because I've had conversations with patients about palliative care, and right away they fear I'm talking about MAID or even advanced directives, and they think I'm talking about MAID, and I made no mention of it. And so I think just if we could put some clarity in place that they are really two different conversations, and we can talk a little bit more about MAID, but maybe just simply put the difference between palliation and MAID.
So I think palliative care is the symptom management and that wraparound care that you get as you move through a life-limiting illness right until the end. If someone is choosing medical assistance in dying, I believe firmly they should have excellent palliative care alongside that, but MAID is quite different, okay? The first thing to know about medical assistance in dying is that it's a choice, but it's the patient's choice. The only person who can choose medical assistance in dying for a patient is the patient themselves. A physician or a nurse practitioner certainly has the responsibility to tell the patient that that option exists for them, just as they have a responsibility to tell them what treatments were involved, what their options are for choosing not to treat, and to let them know that MAID could potentially be an option. But the ultimate decision on whether to pursue MAID depends on the patient and only the patient. It's not something that a physician can choose to do on a patient's behalf. It's not something a family member can choose to do on a patient's behalf. It has to come from the patient themselves. It has to be a voluntary decision. A patient has to have the capacity, which means that they have to be clear enough in their thinking to understand what it is that they're asking for, because obviously it's a very big decision. You know, so I think that's the first major difference between the two. So because someone's choosing MAID doesn't mean that they shouldn't also be receiving good palliative care right up until that point. But the difference is that MAID is patient-driven. It's not as simple as saying that you want to have MAID. There is quite an involved process in being deemed eligible for it.
Yeah, and I think that was a great answer, because I know there's a lot of complexity in even becoming eligible, that it's not even something you could have a conversation about on an interview because it's so patient-driven, patient-specific, and we can't just say, okay, this is everything, because there's so much that goes into making that decision. Tell me a little bit about the process of actually, if somebody, let's say I was interested in MAID and I made this independent decision to proceed with MAID, what would my next step be?
Okay. Well, if a patient has decided on medical assistance in dying, then the first step is that they fill out paperwork and to apply for it. That paperwork gets sent to the MAID Coordination Center here in BC. Every health authority kind of has their own MAID Coordination Center. From there, you are assigned 2 healthcare providers, which can be either a physician or a nurse practitioner, and you have to undergo 2 assessments. So each physician has to find you eligible for MAID, and that eligibility, there are certain criteria that you have to meet to be considered eligible for medical assistance in dying. Once you've been deemed eligible, then it's important to know that at any point, just because someone applies for MAID does not mean that they have to go through with it. At any point, they can change their mind about it and withdraw their consent, and that's fine.
And that's right up until the moment of essentially the day they've chosen.
Yes.
Okay.
Yeah, that's right up until the moment that they've chosen.
Yeah. So I had mentioned that this is really about taking your control back in, your final say in how you want to proceed with death. And I know that there's sort of a moment up until death where you can even say no. How exactly does that work if you're not able to say no, or you are able to say no? Is there something that you can sign beforehand that will say yay or nay to consenting right up until that moment?
Yes. When MAID first started in Canada, there used to be a 10-day waiting period. So once you were deemed eligible, you had to wait 10 days before you could actually have what's called a provision of MAID. The only time that could be waived previously was if someone was at risk of losing their capacity to say yes to medical assistance in dying. Then the physicians could, or the person providing, whether it was a physician or a nurse practitioner, could proceed more quickly in that situation. MAID is an evolving thing in Canada. We're learning new things about it and encountering new situations. More recently, the government has changed it and let that waiting period go. They also introduced something called a waiver of final consent, because people with life-limiting illnesses who want MAID are at risk of losing the ability to answer for themselves on the day. That's why the waiver exists. So it's essentially signing a document in advance that says, if on the day that we've decided to proceed that I can no longer answer yes for myself, I'm giving permission now, because in the end, only the patient can give permission for medical assistance in dying. Okay, that waiver does not require the physician to do it or the nurse practitioner to provide MAID, but it does allow them to do that because the patient has given prior consent for it.
So this is quite a complex conversation, not just palliative care, but MAID, even advanced directives. Dr. Mantha talked about the MOST form. So I just wanted to kind of leave it as an open question. Is there anything else that you wanted to share with the audience that would really provide that added tidbit that you encounter a lot of, or something that you wanted to share that just to put a foundation of what we talked about today?
Oh, wow, that's a big question.
That's a big question.
I think I would say that knowing that the services in the community exist, that if you go on to the Interior Health website, you can find things about advanced care planning, guides to help you think through that, help you open those discussions with family, because those can be difficult discussions to have that some people don't want to think about or talk about, right? So lots of resources exist. There are good resources through the North Okanagan Hospice Society as well, like grief and bereavement services. There is that MOST form that you can discuss with your family doctor, and certainly it's something that we review with patients every time they're admitted to hospital, to know that that discussion is, and those documents are living, breathing, evolving documents. That once you sign a MOS form doesn't mean that's written in stone. Depending on situations, that can change and it can move. But giving time to think about those things in advance, it can really help you navigate difficult decisions when you're not in the middle of a crisis.
Yeah. I can see your heart and your passion for it. I'm so grateful to have interviewed you for this, because I can see the love and the peace that you come with, especially because this is a difficult area of medicine. It really is. And I just wanted to add this, and we'll see if this works for our interview, but I think in medicine, we can often feel that death is a failure. And I think the way that you've really navigated supporting people with palliative care and supporting people with understanding what MAID is and understanding advanced directives, especially even just in this interview, it really alludes to death is not a failure, and it doesn't have to be such a difficult situation that we're feeling we're encountering. It can be, the perspective can be shifted to know that you're held and cared for in this space, regardless of the end result.
Yeah, I would say that death is not a failure. In fact, it's inevitable, right? It's inevitable. And in medicine, we can almost always do something more.
Yeah.
The question is that the right thing for the patient, right?
Yeah.
And what is somebody willing to go through to have more time? You know,
Yeah.
and really palliative care, the fundamental question that underlies all of it is, what does that particular patient want, given that this is the situation that they're in? And it's going to be different for every patient. And I think navigating that with the patient and their goals and their values in mind is probably the most rewarding part of being a physician that I've ever encountered.
Wow. Wow. That's very beautifully said. Thank you. So, as a final note, outside of medicine, what do you do to kind of shift gears out of all of this and what you're working on, and even being a hospitalist, and to just breathe and enjoy Vernon? What are your passions outside?
Well, I think probably a lot like other people, spending time with family and friends, and I think for me also spending time in nature, like, you know, in the stillness of nature, just to rejuvenate and get outside.
Yeah, absolutely. Yeah. So you'll be camping a lot this summer?
Camping this summer, I don't know, maybe paddling, definitely paddling if I can. Yeah.
Good. Well, thank you very much for being here.
Thank you for having me.
You're welcome. And thank you all for listening. Please don't hesitate to reach out if you're, somebody interested in locuming for palliative care, or locuming as a hospitalist, or a resident who's interested in learning more about this area of medicine. We'd love to connect with you and connect you here with Dr. Kirkpatrick. So thank you again for being here, and thank you guys for watching. Bye for now.